move straight on to Professor Hugh Calkins, who will kindly talk to us about key insights from the 2018 HRS statement on arrhythmogenic cardiomyopathies. Thank you so much.
There we go. So good morning. It's a great pleasure to be here. I appreciate the invitation, and I thank you for these two interesting topics. So my charge today is to talk about the 2018 HRS statement on arrhythmogenic cardiomyopathies. I have several disclosures to declare. But I think more importantly, you need to realize this document hasn't been published. It's actually embargoed. It's top secret. If I told you about it, I'd disappear. I'd be blown up. I'd be reported to the feds. So I can't tell you a thing about it. I can tell you a few things, but I can't tell you much. It's going to be presented at the HRS meeting in May in San Francisco. So please join us then, and then you'll hear about it. But I can tell you a few things. The chairs of this document are Bill McKenna and Jeff Tobin, so that's public information. Also public information are the authors that are shown on this list, and I'm pleased to be a member of the writing group. And I think it will be a very impactful document, so stay tuned. I think it really will change the field in a fairly dramatic way, and that's all I can really tell you now. So what am I going to do with my 10 minutes? I'm going to use it to tell you about another, I think, interesting problem with ARVC and a recent paper we have actually that's going to be published shortly on risk stratifications in patients with arrhythmogenic right ventricular cardiomyopathy. So when you think about ARVC, I think about a five-legged stool where you first have to make an accurate diagnosis. Once you make a diagnosis of ARVC based on the 2010 ARVC diagnostic criteria, then you have to risk stratify this individual for what is their risk of sudden cardiac death. Once you've made that decision and you've decided to put in a defibrillator, you then have to minimize symptoms and ICD shocks, and proper programming is obviously essential. You then want to prevent progression. Now, some around the world seem to think this is not a progressive disease, but I'm here to tell you it is a progressive disease because our program at Hopkins has been around for about 20 years, so patients that had early ARVC 20 years ago are now coming back for their transplants. And then you have to remember cascade family screening because this is an inherited condition, and once you diagnose it in one member of the family, you need to screen all family relatives. So my topic today will focus on the issue of risk stratification for ARVC. We published a number of papers on this over the years from our Hopkins ARVC registry, and this is one of our sort of major key papers where we took 84 patients that had a defibrillator put in for primary prevention of sudden death in ARVC. These patients were on average 32 years of age, half were men, they were followed for 5 years, and they presented with either palpitations, syncope, chest pain, or were picked up on routine screening. If you look at how they did, you can see why ARVC, arrhythmogenic right ventricular cardiomyopathy, gets its name. It's highly arrhythmic. I mean, the appropriate ICD therapy rate at 5 years was 60%. And I don't know of any other disease where there's such a dramatic, such a high rate of sustained VT and VF in patients who get devices for primary prevention. And even if you say, well, many of those would have self-terminated, they wouldn't have killed the patient, what about VF, V-flutter cycling at less than 240? Still at 5 years, it's about a 30% rate. And I think even Roger Winkle, who's been working with a defibrillator since it started, would be impressed by these rates of utilization of ICD therapy. When we looked in that study at predictors of appropriate ICD shocks, we found that EP testing was predictive. PVC frequency was a very powerful predictor, and the more PVCs you had, the higher the risk. Non-sustained VT also separated out these groups. And proband status was important, where family members get diagnosed early, they have less severe disease, and they have a much lower rate of arrhythmias going forward. So over the years, if you look at our studies and the other studies that have been published, a number of variables have sort of stood out as predictors of sudden death or sustained VT. Obviously, a history of sudden death or history of sustained VT. Proband status, as we mentioned, with probands being much higher risk than family members. Male gender is a bad actor. It turns out testosterone is an exacerbating factor for ARVC. and of people that die suddenly with ARVC, many are young men. Extent of disease is important, and I think that's reassuring that generally the more severe disease you have, the higher the risk. PVC frequency on 24-hour Holter is important. Cardiac syncope is an important predictor. Exercise plans, we have data that if you cut exercise, you can lower the rate of appropriate therapies by 85%. The results of EP testing, and then, of course, patients' preferences and values, and what risk of sudden death or sustained VT is a given individual willing to accept. The 5 general principles I would like to share with you that we've learned about risk stratification are that the greater the extent of the disease is considered both in terms of electrical disease and structural disease, the higher the risk. Sudden death risk seems to require both electrical manifestation of disease and structural manifestations of disease. So if the MRI is completely normal and you just have T-wave inversions in V1 and V2, that patient's likely to be at low risk. Again, family members are at lower risk as they're diagnosed early. Sudden death in family members not a risk factor in another family member. So just because the father died suddenly or a sibling died suddenly, that doesn't mean another sibling is higher risk. And a 24-hour Holter monitor is a powerful predictor of risk. Now, there's been a number of guideline statements put together. One, Domenico Corrado led, and in this document we went over, sort of broke patients into high risk, intermediate risk, or low risk based on a number of risk factors. And I want to tell you about a recent study that's now in press in the European Heart Journal. It should be published in the next month or two. And I'll share the results of this study with you today. They've been presented previously at the HRS meeting last year in Boston. So the goal of this study was to develop a risk calculator, much like you have for hypertrophic cardiomyopathy. Why not have a risk calculator for ARVC, where you have an app or a tool at the bedside where you can plug in a number of variables and estimate someone's risk of sustained VT or sudden cardiac death. So when we went about developing this model, and this was an international collaboration of 5 different registries around the world, we looked at the literature and we decided to look at the following predictors as we started out. Male gender, because there's been a lot of studies about that. Age, younger age seems to be a risk factor. Recent cardiac syncope, non-sustained VT, number of PVCs, extent of the disease manifested by the number of leads with T-wave inversion, RVEF and LVEF, and the outcomes were sustained VT, cardiac arrest, or an appropriate ICD therapy. So the inclusion criteria were patients with definite ARVC who had not had a sustained arrhythmic event prior to participation in this registry. Again, this was based on 5 registries around the world. And our longtime collaborators are from Utrecht, Peter Lowe's here, and we've worked closely the Hopkins registry and the Dutch registry, but we invited 3 other registries to join us in this exciting effort. So here's the patients we looked at. There were 529 altogether, 226 from Hopkins, 33 from Canada, 147 from the Netherlands, 46 from the Swiss registry, and 76 from the Nordic registry. If you look at who was involved, the 44% were men. The average age of diagnosis was 38. 49% were probans. 64% had a mutation, with the most common being PKP2. Recent syncope in 10%. RVEF was 44. LVEF was 67. And 41% had an ICD. If you look at their event-free survival, it's remarkably similar to the first study I showed with you this morning. And you can see at the 5-year rate, the appropriate ICD therapies or sudden death or sustained VT occurred in 27.5% with an annual event rate of 5.6%. Again, a very arrhythmogenic disease by any measure. When we looked at the variables that we had identified, all of them turned out to be predictive except for LVEF, which we dropped from the model, but the different variables are shown here. Male gender as predicted increased risk 1.6-fold. Younger age was a predictor. Recent cardiac syncope was a powerful predictor. Non-sustained VT, PVC frequency, T-wave inversion. So all of these ended up being fit into the model, which is shown here. So at the end of the day, an app was developed, and you can pull it out right now, www.arvcrisk.com. And in 2 minutes, you can come up with a 5-year risk for the patient sitting in front of you. And this was developed by Laurens Bosman from the Netherlands, and I think it's going to be a very useful tool. So we looked at the performance of this model in a number of statistical ways that seemed to perform well. And I'll draw a conclusion that patients with ARVC are at increased risk of sudden cardiac death. Risk stratification is critical in management to inform recommendations concerning ICD implantation. You obviously need to put the defibrillators in patients who need them and not put them in those who don't. This was, I think, really a remarkable international collaborative effort where 5 international registries collaborated very closely to develop a model and test a model so it's available for clinical use. The performance is better than other clinically available risk stratifications tool, and we hope this tool will be of value in taking care of our patients. And again, if you go to that website on your cell phone right now, you can pull it up and estimate your patient's risk. So again, I want to acknowledge the centers we collaborated with. It really was a fun project. And I will stop there, and I thank you for the invitation to be with us today.
Thank you. Thank you very much.
You'll have to invite me back next year to talk about the...
It will definitely on the agenda, Hugh. Thank you very much for your talks. It's excellent. And the app is particularly helpful, the risk stratification app, which I certainly will download.